Do hormones really make that much of a difference?
As we age, a lot of things change, but mainly our hormones. What impacts does this have on our well-being and sexual health?
As a health coach and a wellness coach, we ask the questions so you get the answers. Let's get started as we ask.
Wait, what?
Hi, Leah.
Excuse me. Hi, Kamna. How are you? That's just today? Today, right?
Today, yes.
We always record at night. This is the first time it's like a midday.
Yes, I am excited because we are having a guest return. And
Emily is back.
Yes, we have so many questions.
Yes.
Thanks for having me back, you guys. I appreciate it. I'm so excited to dive into the topic today.
So many.
We are so excited.
So Emily is a board-certified women's health nurse practitioner, certified nurse midwife, and hormone expert who founded Aurelia Health, which is a modern concierge telehealth company that serves women navigating perimenopause and menopause. Emily's area of expertise includes metabolic health, precision hormone care, and longevity medicine. She resides in the Midwest with her husband, her 4 children. I think I got shocked the last time I said it, and 2 dogs. 4 is crazy to me.
It's a zoo here.
Yeah,
We love it.
good for you. I don't know how you guys are all my superhero friends who have more than 2 kids.
Well, sometimes they're a surprise. A nice surprise, but a
Yes.
good surprise.
Your capacity expands as you have more children.
Yes.
Yeah.
You surprise yourself.
All right.
And you
I take your
become
word for it.
like, oh, that doesn't matter. It's fine.
So
Just become really good at multitasking.
Yeah, very true. So I think where we want to start is if a woman particularly, but I don't know if this applies to men, but a woman particularly is in her 30s and they're starting to see some changes in their body. How much should they be paying attention, and should they be having conversations early about hormonal health?
Yeah, well, I think to begin, one of the problems is that we're not educating women from the beginning of their hormonal life cycle to be just cycle and hormone aware.
Right.
My daughter has the, benefit or misfortune, depending on who you ask, of being raised by a midwife. And so she's been exposed to all of this stuff constantly because I talk about it openly. We talk about periods in my house. We talk about, the hormones that I take and all of the things. But for the most part, it's like, I got my period. Here's the things you need. And the education stops there. We could start very early, very simply with young girls, just explaining to them that in the second half of your cycle, the 2 weeks leading up to your period, you're going to feel differently and your brain is going to work different than it did in the first 2 weeks. Like, can you imagine if you were 12 or 13 and someone had explained that to you? And all of a sudden, like, your moods have a little bit of, there's some reason, right, for the chaos.
Right.
So we start off just being completely disconnected. And that doesn't end. I think then we move into pregnancy and childbearing. And women do have a tendency to get themselves pretty educated about this phase of life, right? They want to do it right. They're motivated.
books.
Yeah. When I was a midwife, I loved working with pregnant women because it was this major inflection point. Like, women who were previously very unhealthy and maybe had a surprise pregnancy would really change their whole lives in pregnancy. And that was awesome to see. Like, there was this way in, right, to changing someone's life. But then again, after postpartum, like, how much education did either of you get about like, what happens to your body postpartum?
None.
How do your hormones change? What nutrients are depleted? I mean, it's a real thing that we have something called postnatal depletion syndrome.
I remember, sorry, I'm sorry.
That's okay.
I just remember after I had my daughter, I was probably crying for 6 weeks. She was also crying a lot, but I kept hearing, what's wrong with you? Why are you crying? Instead of, there's probably something wrong. You probably have an imbalance of your hormones, and let's try to help you. I just remember, and it seemed to happen 5:30 when my husband would come home, I would just release and cry, and they're like, here she goes again, instead of helping and supporting, which is, I think, what more women need.
Of course. Yeah. I mean, that's a whole podcast in and of itself. It's like how we fail women in the postpartum period. We really, just see you later, come in at 6 weeks postpartum for a checkup. We're not routinely checking people's thyroid or nutrient status postpartum. We're not routinely checking, I mean, if you're breastfeeding, you are shutting down your hormones, right? With prolactin, which is the hormone of lactation. So you're not cycling, right? So you have very low levels of estrogen and progesterone, and that huge drop off because you were sort of on Mount Everest in pregnancy, and then you're down at sea level again,
Yeah.
postpartum with very low levels of hormones, and sensitive brains really, really feel that. And then you add to that sleep deprivation, isolation, poor nutrition, all of those things, and it's a recipe for disaster. So, you know, people may have that experience, but I think where we're missing in the conversation is that then from that period, like what happens now? I'm done having babies. I'm 5 years out from having children. Many women are having babies throughout their 30s, but maybe at some point between 35 and 45, they're done having children. And, you know, that bumps right up against perimenopause.
Absolutely.
Because, you know, so menopause, the average age of menopause in the United States is 51 for Caucasian women. It's a little earlier.
That seems early.
51.
Doesn't it seem early, or is that normal?
It's just the middle of the bell curve.
Okay.
So it's when it's the average number. Of course, there'll be people beyond that and people before that. Okay. So you could have.
So menopause actually is when your periods have stopped for over a year.
For 1 year.
Officially.
Exactly.
So you can say, now I'm in menopause.
Correct. Which to me is pretty irrelevant, actually.
Okay.
Because I see it all as a continuum. And if you're waiting until menopause to do something about any of these things, you've waited too long, in my opinion. That doesn't mean that if you're already menopausal and you haven't done anything, you shouldn't do something now, right? You get the most benefit the earlier you start.
Okay.
Right. So you're postpartum and potentially perimenopausal, because perimenopause meaning really ovarian aging. So your ovaries, which secrete estrogen and progesterone, age faster than the rest of your body. They have a lifespan that's shorter than the rest of your organ systems. Okay. That's just something that's unique to us as mammals. There's only a few other mammals that go through menopause. Okay. That aging can take place and be really in an accelerated sort of phase for 10 to 15 years before you've been a year with them. Mm-hmm. Right. So for some people, it could be just maybe 7 years that they're having symptoms and signs in their labs. Now, this is finally getting talked about, which is great. I think what we're missing in the conversation is that, you know, we don't suddenly say, well, now that I'm 32, I could be within 10 to 15 years of menopause, so I should start to care about my hormones. Like, we should care about women's health through the lens of the functionality of their hormones from day one. We should always care, because how our ovaries are performing, if we're ovulating, right? If we're producing progesterone, if our estrogen is sufficient or not sufficient, if our hormones are working really to our benefit, this is a global problem for women's health, right? We will perform much better, feel much better, our metabolism will be better, our mood will be better if all of these hormones are working to the best of their ability. Now, up to a certain point, there's so many things that you can do to impact sort of hormonal performance, if you will, right? Okay. Obviously, I always start with the very basics, the lowest hanging fruit, just getting adequate sleep in a very dark and cool room, adequate deep sleep, time for your body to repair, right? This is the number one thing that you can do, balancing your circadian rhythm to really start to support cortisol, your adrenal function, which downstream really does impact how your estrogen and progesterone are performing. So I talk to people about sleep and rest and stress, and then blood sugar are like kind of the first places where you can make a lot of movement in terms of how well your hormones are performing, really at any age. But that's something that you should start no matter where you are, but especially if you're in your mid 30s to mid 40s.
Can I back up a little bit and ask a question that might be maybe a lot of people know, but I maybe don't know? Is I know we need estrogen and we need progesterone, but I think there's a lot of other hormones that for a female that are really crucial for like optimum health. Am I right or wrong?
Totally. Yep, absolutely. So when we talk about cycle health, I'm mostly talking about estrogen and progesterone, and then to some extent insulin and cortisol, because they impact sort of how well the brain can communicate with the ovaries. But there's an adrenal hormone, testosterone, also somewhat produced by the ovaries. That's very important for sort of overall well-being, mood, sort of the get shit done hormone, if you will, libido, all of those things, body composition are all impacted by testosterone. Thyroid hormones are incredibly important. And in fact, I will never treat a hormone deficiency syndrome patient or any kind of hormone patient without looking at a full thyroid panel. Because if thyroid is off, if, for example, T3, which is not commonly checked in medical practices, if T3 is off, you can have lots of downstream effects from that, issues with progesterone, issues with all kinds of functions in the body, cholesterol rising, things like that. So those are all essential. And this is why like no hormone can be treated in a silo. You can't go in and be like, I think I have a problem with progesterone. I think I have a problem with testosterone. It's like, you really have to look at the global picture of a woman's health. You have to look at her metabolic health. You have to look at her inflammation, her blood sugar. And then you also have to look at her hormones and say like, what's the most important lever to pull first?
Oh my God, that seems so overwhelming.
I mean, it's overwhelming for someone who's not doing it.
Right.
Right. It's overwhelming to me for like the car mechanic to be like, well, you got to do X, Y, Z. I'm like, you take care of it. Like, that's why
Yeah.
I do what
You
I
go to
do.
a specialist.
Right.
Yes.
Right. Right. Good analogy. Wow. Okay.
Can you
so-
imagine if someone was like, this is what your car needs? Go ahead.
Yeah.
Like, it's amazing to me that we try to DIY all of this stuff. Right.
Well,
And part of it is
Oh.
just because there's nobody out there to help. But it's amazing how much women just try to DIY. It's like the, man in the plumbing kind of situation, right? Like how many people's husbands have tried to, not to stereotype, but, and this has happened to me with my husband. It's like, just call the plumber, honey. And then we have a flood. And then it's like, then the
Right,
plumber
right.
gets called, So I don't know why we're so comfortable with remaining unwell. I think some of it comes from there's just a lot of distrust with medical providers around hormones, because most women have had an experience of presenting and saying, I feel this way, and then being dismissed and
Yes.
not being offered any solutions. And so we just kind of give up on the system.
Yeah.
I think we're also just sometimes hyper independent to a fault as a coping mechanism. And so
Yes.
we, do ourselves a disservice. We have people all the time that take 6 months before they sign up with us, and they're not getting better during that 6 months. They're just trying
So
harder and getting fewer results just because what's simple to me, because I've been doing this for many, many, many years, is really complex to the average person who's probably
Yes.
really educated and great at something that I'm not good at,
Yeah. Wow. Okay.
Were you going to ask a question, Leah?
I have so many things going on in my head right now, but you said something about like things that is there stuff we can do at home to help as well, like over the counter stuff, or
I think it depends on what you're asking for help
Okay.
with, right?
Okay.
So are you saying like if you think that if you're over 35 and lately you haven't been sleeping well,
Okay.
like that, like the sort of the most common early signs of perimenopause?
Is that one of them? One of the signs is you're not sleeping well?
Yes.
Really?
Like insomnia, ruminating thoughts, waking up at 3 or 4 in the morning, waking up and not feeling rested, even if you did get good sleep.
Leah feels so seen right now.
Well, I always feel seen about whenever anybody says sleep is so important, because I'm like, yes, finally. But like sometimes let's just talk about me. All right, let's
Sure.
talk about me. I feel like my joints hurt so bad, and I wake up and I'm just like in pain, and I go to the doctor and they're like, well, you're 45. That's normal. And I'm like, yeah, but they just told me today to take 4 Advil 3 times a day. And I told Kamna, I'm like, that can't be the solution to this. And it's
Right.
like,
Then you won't have a stomach in like 5 years.
what do I,
Yeah.
like, and I don't see, that's the thing. Like, so is this real? Am I really just gonna be pain forever? Or is it like, do I need to get my hormones looked at?
Yeah. So no, you should never have to be in pain.
Right?
We have way too much technology in the world to tell women that they have to live in pain. And number 2, at 45, yes, your hormones are definitely on the decline. That can loss of estrogen can absolutely cause joint pain. But something else that can be going on is you may have some subtle autoimmune changes going on, some inflammation, right? So there's always 2 things that are true, at least in a perimenopausal or menopausal picture, right? It's like we
Right.
have hormone decline, but we also have all these other systems that are aging on their own, but then some of their aging and fall apart is accelerated by the loss of hormones, right? So for example, our
Oh.
metabolism, that fall apart, that insulin resistance is accelerated by the loss of estrogen, right?
Wow.
Our immune system may be becoming a little bit weaker, but some of that immune dysregulation and weakness is also accelerated by the loss of estrogen. So 2 things are true, right? That's why I think it's so important to look at the full picture and to say,
Okay.
here's what's going on with your hormones, right? You're having, maybe we like to look at hormones through the whole cycle if possible. We encourage women to get home hormone monitoring kits. We love the Mira kit, where you pee on a stick every day or every other day. It's great. It's pretty affordable. And you can get a whole picture. You can get a chart basically of like what your hormone pattern is for a month. And you can start to correlate those highs and lows with your symptoms, which is so empowering. And I just love that like these technologies are available now. Like they
Right.
weren't available, 10, 20 years ago. And I just find them so helpful. But we also, want to like, I think just good history taking, like good old fashioned medicine, like if you were to tell me that, Leah, and you also have sleep issues, and maybe you also have some brain fog, or you're like word forgetting, or you're leaving your keys in the pantry or whatever, like these are all very related to, yes, aging, but what's the most accelerant part of aging? Hormone loss. So we have to work on both, right? You guys are health coaches. You have to do all the lifestyle things. You have to do all the circadian rhythm support, no blue light after a certain time, stay off screens, have a wind down routine, don't eat too close to bed, sleep in a cold room, completely dark. I mean, you have all the things, right? Like these are important. You can't not do those, right?
Right.
But you also, like, I don't know, I'm so tired of a world in which all we have for women is like more advice on how they can work harder.
Yeah.
Yeah.
Very
Just
good
so
point.
over it. It's so tired. Like, I don't know, the women that I know and meet, they will do whatever you tell them to do.
Yeah,
But like,
absolutely.
also, I don't need to be causing unnecessary suffering. Like, we've all worked really hard already in our lives. And so I see hormones as like a real leg up, because if someone's committed to continuously working to get better in the lifestyle area, but not kill themselves, right? The hormones are going to be such a leg up. Like, it's so much easier to sleep if you have proper hormones on board. It just is, right? Our circadian rhythm, actually the sensitivity to light, the center of your brain that is sensitive and responds to light and knows how to regulate cortisol and melatonin, is regulated by estrogen.
That makes so much sense, because as soon as I'm probably 45, 50, I couldn't tolerate any light. I would just be awake, and I had to buy a eye mask
Oh,
because
yes.
I just couldn't sleep.
Wow. Yep.
That makes so much sense to me.
I know. Think about like our teenagers when they get to sleep in the middle of like whatever.
Yes, that's who
Under
I
any
used to be.
circumstances. And you're like, how?
Midday, they just, yeah. Wow.
How?
Okay. This all makes so much sense.
Yeah.
Okay.
So, I think that I think that, modern primary care should be hormone care. We say at Aurelia that we're, primary hormone care for women. We're not going to be like, you can't traditionally qualify us as primary care providers because we don't treat strep throat and, those kinds of visits. But we do what I think is the most important piece for women, right? Is like disease prevention, management of metabolism, and all of the things that fuel chronic disease. By the time you're 40 years old, 76% of women in the United States have one chronic disease.
Ugh.
55% have two.
Wow.
Wow.
Right? So like, we're dealing with a very sick population, but if we don't utilize hormones as like a lens for how to treat these women, we're just, again, making everything an uphill battle, right? Like, in the context of hormone decline, we can really throw people a bone by restoring some of the fundamentals of their physiology so that then things work better, right?
Okay, so let's talk about that a little bit. So if I know there was some controversy with hormone replacement therapy, and there was some study, and I was just listening to, I don't know the exact details about how they were studying postmenopausal women, 60 and plus, and they found one case of breast cancer. They stopped the study. They didn't do any long-term evaluations, and they said that hormone replacement therapy causes cancer, breast
Right.
cancer
You did a
specifically.
pretty good job. Good job, Kamna.
Thank you.
So the
good.
study you're referring to is the Women's Health Initiative. It was the largest study to date ever that followed a huge cohort of women. Actually, they were mostly healthcare workers, which is really interesting. They were nurses. If you ever worked in a hospital, nurses are not the most healthy population. But they were taking these women that most of them were 10 years post-menopause, and they were putting them on hormone replacement therapy, which at the time, the most typically prescribed hormone replacement therapy was oral Premarin, which is a form of conjugated equine estrogen. So it's made from horse urine, estrogen metabolites, right? So slightly different than like what a human body would make. And it was given orally, which has its own problems. And then they were giving synthetic progestin in the form of medroxyprogesterone acetate for the women who had a uterus. And that is because if you give a form of estrogen to a woman who has a uterus, you must also give some form of progesterone, which is my preference, or progestin, to sort of balance the effect of estrogen to prevent the uterine lining from building up, sort of endlessly building up, which, is a risk factor for uterine cancer. And what the things that they were looking for in the study where they wanted to see, measure cardiovascular incidents, so stroke, heart attack, those kinds of things. They also, were looking at breast cancer. The media went into a frenzy when they came out and said, we're going to stop this study because we're concerned about incidences of breast cancer. what they found later on is that, when you looked at actual risk and what, the actual increase in risk and incidence compared to the relative increase, right? So if you say there was a 25% increased chance or 50% increased chance, that sounds like really crazy. But if you're talking about like one case out of 100,000 to two cases out of 100,000, right? It's not really that big of a difference. The other really important thing to know about this study is that the estrogen only arm, so even though they were using kind of a crappy form of estrogen replacement, had no increased risk of breast cancer. And in fact, the women who were on that therapy had a lower risk of dying from breast cancer.
Oh.
So, which, has been shown a few times again that like estrogen therapy seems to be protective. It was only the women taking medroxyprogesterone acetate, the women with a uterus, who fell into that slight increased risk, but it wasn't statistically significant at the end of the day. But of course, everybody's been affected by breast cancer. Everybody's afraid of it. But, one just sort of broad thing to understand is that like since this study came out and, rates of hormone replacement therapy use went from almost half of women, eligible women, to now it's less than 4% of women on HRT, over 40, eligible women, less than 4% of the population.
Does insurance cover it?
Oftentimes, yes.
Okay.
Yes. So but we haven't seen a decrease in the rates of breast cancer, right? We've seen only an increased rates of breast cancer and increased rates of cardiovascular disease and all these other things. So there were some increases in the incidence of cardiovascular incidents. But what that needs to be understood through the context of is that, again, we were starting these drugs in people who are 10 years past menopause. So some of the arterial stiffening and some of the sort of age-related and estrogen loss-related effects to the cardiovascular system had already been well established. We were also using an oral form of estrogen, which increases clotting factors and increases clot risk, right? Any cardiovascular incident is related to clotting, right? So it's not a great choice to put a woman who's 10 years post-menopause on an oral form of estrogen. Okay. So it kind of put us into a dark ages for many, many, many years. We're now recovering from that. There's finally sort of a lot of people questioning all that was done in that study, everything that's happened before or since then, and really working to, change the status of menopause care, perimenopause and menopause care for all women, because not only is it an issue of suffering and kind of just a human rights issue of like, we don't want women to suffer. And I'm not saying HRT is not a magic bullet, but it is a huge leg up. Right? We still have to be committed to our health practices in midlife, but it's a huge leg up. But then secondarily, there's a lot of potential benefits and health prevention aspects of the use of HRT.
So you like to use hormone replacement therapy in your practice?
Correct. Yep. Our whole practice is really our foundation is that we do very innovative, customized approaches to hormone replacement therapy alongside really, radically supportive lifestyle intervention programs.
I'm assuming that it's customized to the person depending on what symptoms or what they're experiencing. Is that?
Yeah, like what their labs are showing, what phase of perimenopause or menopause they're in, what their lifestyle is. So do they want something that's more set it and forget it, or are they okay with more complication, for potentially more benefit?
Okay, I'm going to ask you something, and don't judge me where I got my information, but I was watching a reality TV show, and they were getting testosterone shots or something.
The women or the men?
The women.
Okay.
In their butt, and then they couldn't exercise or something for a couple of days. But is this something that people do?
Yeah, people do take testosterone by injection. I don't do testosterone injections. I find that like transdermal cream and gel are perfectly acceptable and get levels up to perfectly acceptable places.
Okay.
For women, and I prefer to try to replace a hormone in a way that would mimic, to the best of my ability, the way that the body would release the hormone. So if you give an injection that lasts like a week or a month, depending on the formulation, like you're going to get sort of a bolus, like a higher dose in the body, and then it's going to decline, right? So you're not getting a steady state dose. You also can't take it away if you're having a side effect. So if you get too much testosterone, that's not fun, right? You might grow hair on your face. Your voice might deepen. You might lose hair on your head. You might have no sex drive. So like you don't want to overdose on testosterone, which is another reason why I like the topical applications, because they're much easier to monitor and dose
Control.
adjust. Yeah.
Yeah.
So you would say sorry, Leah, and keep interrupting you, but
That's okay.
testosterone is really important for sexual health too for women.
Yep. I would say that estrogen is more important for desire, climax, and all of the sexual functions, in my opinion. Testosterone is also important. Every woman needs estrogen, in my opinion. So not every single woman needs testosterone. Just really depends on kind of her labs
Oh,
and her status.
Oh.
Yeah. If you actually like are looking at people's labs and if you replace estrogen appropriately, in my opinion, not everybody agrees with me.
oh, what do you mean?
I just think there's, we're in a time and space where lots of clinicians are trying to figure this stuff out. And because
Okay.
we weren't trained, none of us were trained on this in school. I got very minimal training on menopause and perimenopause in school, probably better than most. I got a lot of training on like just, how we should be screening and kind of taking care from a primary care perspective of women in midlife. But the big piece that was missing was like, all of this is driven by hormone decline. Like that's the
Okay.
part in parentheses that was like completely left out. So we're all trying to figure this stuff out. And there's, we're working with the limited data that exists, but the best way to learn is to have a lot of people that you're treating, take care of a lot of patients, right? So even as my business grows and I step more and more into an executive role, I still maintain a panel of patients because I learn the most important lessons from them, right? And
Absolutely.
you can't replace that volume experience, right? Of just treating woman after woman after woman, looking at lab result after lab result after lab result and correlating it. I think it's that and like learning from people who've been doing it for even longer than me are the best tools that I've ever
Mm.
had as a provider.
So I want to talk a little bit about sexual health as we age, because I think the image I get from talking to a lot of women is, once, especially after your period's gone, you kind of lose interest and you just don't want to do it anymore. And things are not quite as they used to be. Is this an inevitability that we're going to lose our sexual function?
Or the desire? You mean?
Yeah. I mean, I think that there's wide bio differentiation and sort of individuality here. And there are certainly like sex is a very complicated thing because it's not just physiology, right? It's relationship, feeling safe, how regulated your nervous system is, right? Connection, all of these things, right? So that aside, absolutely, like you're just speaking from a physiologic perspective, the pelvic organs, the organs of sexual function, the clitoris, the vulva, the vagina, the G spot, right? All of these bodies and areas in the female sexual, in the pelvis and in the pelvic floor, they all change in the absence of hormones. So as estrogen declines, right, you actually have tissue atrophy, clitoral atrophy, and atrophy means like, you know what atrophy means? Like if you have a big muscle and then you have no muscle.
Right.
They recede and go away, right?
Yeah, they
You know how
like
you
dry
have
up.
like labia, you have a labia majora and a labia minora. The labia majora like recede and go away. Your vagina starts to look more like a little girl's vagina as you get older.
Huh.
Oh,
Yes, these things actually happen. So, and the consequences of that are, yes, like decreased sexual function, but it's also a lot of urinary issues and bladder issues, right? And increased
oh,
risk for your UTI, right? We would save millions and millions of lives if we would start to prescribe vaginal estrogen to every woman over a certain age, because it would maintain the tissue integrity and prevent the incidence of UTI. And UTIs are a leading cause of disability and death for older women, right? Because they often don't present with the same symptoms. It's not burning with urination, right? They start to have mental status changes, right? There's a whole host of things, and it's a huge reason for hospitalization. Or a reason for complication, post-op hospitalization. So someone breaks her hip, then she gets a UTI, right? She ends up dying from sepsis because of the UTI. So just like from a very public health kind of zoomed out macro perspective, like we are so missing the boat here. And there's a lot of really amazing physicians and other practitioners who are really taking up this fight. I don't want to take credit for any of it because although I, promote these things, I haven't really done anything on the political side. And some of these women really have. Dr. Rachel Rubin is a huge advocate for vaginal estrogen and is working to remove, there's, black box warning labels on vaginal estrogen still that really prevent it from being prescribed as ubiquitously as it absolutely should be.
so if a female has a tendency for UTIs, they should be using a vaginal cream.
Absolutely. Yeah. I even use
And
it on very young patients. It helps to maintain and restore the microbiome. It maintains tissue integrity. It assists with circulation. Right. And so there are commercially available and covered by insurance, easy to get vaginal estrogen formulations that you can, get from any pharmacy. All you need is a prescription. So I would argue that it should be available even without a prescription, quite frankly, because it's so safe.
does
And
that help with sexual health then too?
It absolutely can. Yeah, for sure can. So it can help with vaginal atrophy. It can help with, pain with intercourse. Absolutely. All of these things, this would be like the first line treatment. There are other things that you can do. And, getting systemic estrogen back up to optimal levels or, even above sort of 80 to 100. It's kind of like the bottom, like the floor, I would say, for an estrogen level for a woman deep in perimenopause or menopause. That can also help, right? That can help with the brain. It can help with desire, help with climax and things like that. But there's a variety of other things that you can do, right? We often use a formulation that has estrogen and testosterone that's applied vaginally.
okay.
That can also help, especially if people are not responding as strongly as we would like them to vaginal estrogen alone.
Very interesting.
I know.
Yeah,
Okay.
and there's even a topical formulation. We call it Scream Cream in our practice. That is sort of like topical Viagra for women. So it's made with sildenafil, which is the active ingredient in Viagra, and it what that does is it's a vasodilator. So it makes like all the blood vessels become more engorged more quickly, right? And so you're more aroused. It's kind of like a female erection. It helps with the female erection.
They
Mhm.
should be promoting that because they promote Viagra all the time.
Yeah. Well, I don't believe that there's a commercially available uh, product for this. We compound it. It
Oh,
was made by several compounders. So some of the bigger telehealth companies are making it. We offer it to women in our practice, and we have it compounded and shipped to you. But
wow.
it can be a big help, right? But remember, just like everything, like sex and sexual function are always multifactorial, right?
Yes.
So you like want to look at the whole picture. You sometimes it's like we have a saying in our practice. It's like we've done everything, but we can't help her have her eat, pray, love moment. You know,
Mhm.
like we can't do that for her, right? So like we can give you all the things and we can fix your hormones and like it may be a relational issue, but 99% of the time I think the problem is that women are told like just have a drink and deal with it, sex is just going to hurt at this point, like sex leaves the marriage and that's just part of getting older. Like we're told all kinds of things by I can't even bring myself to say well-meaning providers because I just feel like at this point it's unacceptable to say that to any woman, but women are told that all the time. So well, the message I want people to know is that there are absolutely solutions. It's not you. You're not broken. There are so many covered by insurance options that we can employ to help you feel better and maintain that part of your life. Because for a lot of women, this is like when they're finally having time to reconnect with their partner.
Right.
Hmm.
Maybe they're traveling more, they're spending more alone time. I mean, if you've ever seen that graph of like of your lifetime and who you spend all your time with, it's like you spend, a lot of time with your children up until like age 5, and then it starts to decline. And then like you spend a lot of time with, like most of the time you spend with your partner is actually as you get older, right? And then it's a lot of time alone, right? There's time with coworkers, time, and so it's just you really have to kind of prepare yourself for the fact that like past 60 many people are like don't know what to do with themselves because they're spending 24/7 with their partner and they haven't spent that time with them like for the previous 30 years.
Yeah, very true.
So
Yeah.
like we want to make this relationship as rich and fulfilling as possible. It's absolutely
Right.
unacceptable that women are experiencing pain with intercourse and it's being brushed off as if it's not a primary care basic human right and need.
I think it's a good conversation to have because I know I've talked to people who have said, I just don't have any interest. It doesn't even interest me at all. And my
Mhm.
husband wants it and I just don't.
Yep.
I think
A
that's
lot of
probably,
that is hormonal. A lot of that is bandwidth, just how boundaries and bandwidth and like how much people are taking on in midlife.
Mhm.
But I would say like my job and my position, because I'm not a sex therapist and I'm not, I'm not a life coach. Like my job is to see everything through the lens of hormones.
absolutely.
It's to me, everything is hormones until proven otherwise.
Okay.
Like, because if I can't tell you what's going on with your basic physiology, how can I tell you what it might be? Right? I can only tell you like this. If what is going on, Like,
Yeah.
Leah, Kamna, if I did your labs and I looked at all your stuff, I could be like, here's the status. This is what I would correct. And this is what I can do, right? And then we see like what improvements we can get. Doesn't mean that the other work
But
goes away.
to me, it's a little bit of a relief to know that there is a fix, because say you still hopefully love your partner and you enjoy spending time with them, but you just don't have the desire to know that potentially there's a fix for that is really
Right.
encouraging.
Yep. There
Mhm.
absolutely is. 100%. I mean, we see it all the time and it doesn't happen overnight.
Right.
But like I really love and appreciate the women who like will relentlessly continue to work towards that, we always try to remember to ask, I say that because I don't want to say like we always ask and I forgot that one time and I want to stay humble.
Sure.
But like a lot of women don't bring it up, unless you ask. And we know that's the case across the health, continuum for women, that women aren't going to bring up their sexual health issues unless providers ask. But you have to ask. It's our job to ask and to make it a safe space, because a lot of women are embarrassed because there are doctors out there who will say to you, like, I don't know, have a glass of wine and suck it up. This is just part of of getting older.
Okay, so if we wanted to call you, we go to what you have a website?
Yep. So my company is called AureliaHealth.com,
Okay.
or AureliaHealth.com is our website. We currently serve 12 states, including the state of Ohio. So all of our states are listed there, and we're expanding this year into hopefully Texas, California, New Jersey, Tennessee, Pennsylvania, Illinois. So we have a bunch on the roster kind of coming up, and some of the Eastern Seaboard, like Maryland, Virginia, things like that. So if you are listening and you're not in one of the 12 states we're currently in, send us a message, put yourself on the wait list, and we'll notify you as soon as we're there. And we're not a traditional medical practice in that we don't do like ongoing a la carte visits, right? You can come see us once if you want to, just to get your hormones checked and see a practitioner, which is so useful, right? And everybody should do it, honestly. It's what I've always had this sort of obsession with what's really good primary care. What should it be for women? It was something I studied when I was in grad school. Because it just misses the boat, right? We've got OBGYN on this one side, you get your pap and breast exam on the other side, you're going to your doctor, and like they don't even really know how to treat women.
Right.
And you just kind of feel like lost and like your time is wasted on both ends. So like, can we combine them, right? Can we really zoom out? We do a panel of 56 different labs, which is at least 2 to 3 times more what you would get from your primary care doc or OBGYN. We look at deep into thyroid and progesterone and estrogen and metabolic function, inflammation, nutrients, all those things, autoimmunity. We look to check if you have an autoimmune condition or autoimmune thyroid condition, which a lot of women don't get checked for. And then we spend an hour going over your results with you. And then you meet with one of our health coaches to help you kind of like implement these things. And that might be all that you get. And then you can go DIY it yourself. Or if you want to like join one of our programs, we have a 6-month onboarding period where we really pair you with a coach. You work closely with your RN and NP. You get to, participate in our course and our group program. And then after that, you kind of, we just feel like we need that much time to kind of like make a 180-degree transformation for people, really help them get their system in place. Yeah. And then we can stay your primary hormone care provider for life, and you pay like a low monthly fee to stay a member. Just includes all your visits and stuff.
We have a code that you gave us for our listeners if they want to use to come see you.
Yep. Mm-hmm. I think they get $50 off that initial visit, which is great.
It's awesome.
Yeah. And we don't really, full disclosure, we really don't make a profit off of those that much. Like it's really just a way for us to share this work with more people. It includes like we cover the cost of the lab. So there's no hassle with like trying to bill insurance and if it's going to be covered and do you have a copay and all those things. And it really, like my mission is, what I would really love is to be able to get like 1,000 people to do that every year, because it would change their life, right? Yes. It's like, we spend money on so many things, and we expect this broken system because it's covered, like to fix our problems. And it's like, we have one life to live. Every year that passes, we lose more of an opportunity to intervene and to change our trajectory, right? If you change an airplane's path by 1 degree, it ends up in a different country, right? So sometimes it's just a few targeted changes that you make with your health when you understand it better that can really change where you're headed and where you end up in 5 years.
Yeah.
Thank you so much. I have learned so much in this episode.
I know. Thank you so much for having me. It was a pleasure.
So awesome. Thank you again.
My pleasure.
How much?
We hope you enjoyed today's episode. All the information provided is meant for education and entertainment purposes only. Please consult your physician before making any changes.
If you like this episode, please give us a 5-star review. Also, share this episode with someone who you think would enjoy it. If you have topics you want us to investigate, please message us. Thanks!